Good afternoon and welcome. Welcome to the annual Oscar Romero Solidarity Lecture. My name is Catherine Geddick-Soltis, and I have the privilege of directing the Center for Peace and Justice Education here at Villanova University. And for many years, our center has organized annual lectures to celebrate Oscar Romero, Saint Oscar Romero, a man whose life and his death exemplified solidarity with the poor and marginalized. Today, in March 24th, is Romero's feast day. 41 years ago today, he was assassinated in the middle of celebrating Mass, and he had known for some time that his life was in danger. Romero was appointed Archbishop of San Salvador in 1977 in the midst of unbelievable violence and oppression. After coming to realize the extent of the suffering of the people, he became an unfailing voice for the voiceless. He stood up against poverty, social injustice, torture, assassinations, and disappearances. He has become a model for all those who are committed to justice, dignity, and solidarity. Today, we have the great honor of welcoming two individuals who indeed share those commitments. Dr. Monique Gary and Reverend Naomi Washington-Leapheart, who will speak on the intersection of faith, race, and COVID-19. But first, some very brief notes about our webinar today. We are recording the event and plan to make it available to the Villanova community afterwards. As you can see, we're also making live transcription available to increase the accessibility. We are going to have time at the end for questions, so we ask that you would submit your questions through the Q&A feature below, and we'll try to get to as many as we can at the end of the presentation. We thank you for taking the time to join us this afternoon. And I'd also like to thank the hardworking faculty and staff of the Center for Peace and Justice Education, especially our new program coordinator, Katie Regan-Linehan. And another new colleague that we have had the pleasure of welcoming this year is our Vice President for Mission and Ministry, Father Kevin DePrinzio. Father Kevin has graciously offered to introduce our two speakers, and now I have the pleasure of introducing him. Before his appointment this year, Father Kevin served the Villanova community in a number of roles, including as faculty for the Department of Theology and Religious Studies, as a member of the Augustinian Institute, and even as vocation director for the Augustinians. We are grateful that his vocation has come to include this work as vice president. And it is fitting that he joins us tonight, this afternoon, given the extensive work that he has done over the past year to attend to the demands of faith and to the challenge of race as we all struggle in the midst of this COVID-19 pandemic. So I thank you, Father Kevin, for all you do, and turn it over to you now.
Well, thank you, Catherine, for that nice introduction. And in the spirit of St. Augustine, who often spoke about the mutual sharing of goods, the ministry that I've been asked to undertake can't happen without the wonderful good people of other people who are about the same thing. So I thank you, Catherine, for your leadership in mission and ministry and with the Center for Peace and Justice Education. And as Catherine had invited us to consider about the legacy of Oscar Romero, St. Oscar Romero, whom I'd like to say is not only an advocate for the oppressed, the marginalized, the voiceless, but also an agitator of and for the gospel. And so I'd like that this solidarity series, this talk tonight with our two esteemed speakers are going to be inviting us to not only be advocates, but also to be agitated by their challenge that they offer tonight. So I thank them in advance for being with us and for offering your own reflection on your own ministry as well. Dr. Monique Gary is a board-certified, fellowship-trained breast surgical oncologist and medical director of the Grandview Health Penn Cancer Network program in Sellersville, Pennsylvania. She completed her medical degree at the Philadelphia College of Osteopathic Medicine and her general surgery training at the University of Massachusetts, as well as fellowship at Georgetown University. As a physician, researcher, advocate, and expert on cancer and healthcare disparities, Dr. Gary is passionate about developing integrative, holistic, and innovative approaches to cancer treatment, prevention, and survivorship, both in our region and throughout the world. Dr. Gary serves on the board of several national oncology advocacy and empowerment organizations. She's recognized as a leading physician of the world and top breast surgeon in Pennsylvania for 2017, 2018, and 2019, and is a fellow of the American College of Surgeons, the highest distinction awarded to surgeons in the nations. Wow. She's been featured in a variety of interviews and podcasts. She can be heard daily on Urban One radio stations in Philadelphia discussing COVID-19 and our community during the daily check-in with Dr. Mo. And she can be heard weekly as the co-host of The Doctor Is In on blackdoctor.org. So thank you, Dr. Mo, for being with us tonight. And also, we welcome and thank Reverend Naomi Washington-Leapheart, who is the Director for Faith-Based and Interfaith Affairs for the City of Philadelphia. She works for the Mayor's Office on local and national matters that impact diverse communities of faith. She's been City Hall's primary advisor on COVID-19 guidance and messaging for houses of worship. She's an adjunct professor of Theology and Religious Studies here at Villanova, where she teaches a variety of courses, including 2 through our own Center for Peace and Justice Education. Do Black Lives Matter to God? A Theological Exploration of Race, Suffering, and Resistance, and Agitating for Justice, Faith-Rooted Community Organizing. In 2019, Naomi received the Polehouse Stracciolini Award for Teaching Excellence here at Villanova. She's often invited to lecture and consult for various student and faculty groups within the university, and as a multi-faith advisor to campus ministry. She directs the Villanova Gospel Choir and preaches in ecumenical worship services. So not only is Naomi a friend of Villanova, she is part of the Villanova community. Before working in city government, Naomi was a faith organizer for Power Interfaith, a multi-faith, multiracial network of congregations in southeastern and central Pennsylvania, and she once served as co-pastor and minister of music at the Wisdom's Table at St. Peter's United Church of Christ. Naomi was also the faith work director for the National LGBTQ Task Force, the country's oldest national LGBTQ justice and equality group. In 2019, Naomi was named one of 9 LGBTQ faith leaders to watch by the Center for American Progress, and was included in the Route 100, an annual list of the nation's most influential African Americans ages 25 to 45. So welcome, Naomi. And with that, I will take it over to you, Naomi, because I think you're going to speak to us first. So thank you to both of you on behalf of Villanova.
Thank you, Father Kevin, and thank you, Dr. Catherine. Thank you to the Center for Peace and Justice Education, and thank you, Villanova, for having us begin and hopefully not end the conversation on campus about faith, race, and COVID-19. I'm going to share my screen and get started. So I will let Dr. Gary bring her greetings in a few slides. One of the things I want to start by saying, as a faith leader who has tried to provide guidance to faith communities during COVID-19, is that pandemic faith continues. That it was not necessarily a foregone conclusion, but studies have now begun to show that people across America and people certainly in the Philadelphia region have continued to be faithful. They have even declared that COVID-19 has strengthened their faith in some ways. And at the same time, what we are seeing is a tension, right, among people of faith who are wrestling with questions about God, about purpose, about healing, about hope, about cure, about wellness in the midst of COVID-19. So while people are plugging in perhaps more deeply to their spiritual commitments, to their moral core. At the same time, people are wrestling and on spiritual grounds with the continued devastation of COVID-19. So this is an appropriate conversation for us to have. People haven't surrendered their faith. In fact, they've tried to make sense of the pandemic using their faith. So one of the things that we must do is interrogate how faith is being used. What kind of instrument, what kind of tool, what kind of strategy is faith for people as we try to live and survive through the COVID-19 pandemic? And one of the, I think, core scripture passages in the Christian tradition that many draw on is this passage from the prophetic book of Isaiah, which refers to having been healed by the stripes of the one who was tormented and beaten and who died ultimately for our sins. This scripture passage is often framed as pointing toward Jesus, right? And let me just say here personally that I grew up in a faith community that often invoked this scripture passage, that we are healed by Jesus's lashes. We are healed because Jesus paid with his life for the sins of the world. And so in that way, faith is framed as wellness. Like if you have faith in Jesus, you will be well because Jesus made it so on the cross. Through the blood of Jesus, we are healed. We've been healed. And so that's, I think, a predominant theological perspective that is engaging people of faith, that is challenging people of faith during this COVID-19 pandemic. So faith as wellness, not faith leading to wellness, not faith as a path to wellness, but faith itself as a kind of guarantee of health and wellness. And this is a theology that certainly is pushed to the limit by a global pandemic like COVID-19. Certainly many people of faith, many believers in Jesus have unfortunately died due to complications of COVID-19. And so this theology is a rooted one, perhaps a popular one, and is being pushed, I think, to its limits during something like a global pandemic. So what we got to do is interrogate the theologies of healing that we may have inherited. I've really learned a lot from my comrades and friends in the disability theology community who push me to talk about wellness and wholeness instead of cures and sort of perfected bodies, right? In a sense that bodies without any kind of disease, ailment. So theologies of healing need to be robust to include healing that doesn't connect to a sense of cure. We certainly have seen over the past year that many folks who've had COVID-19 and recovered from COVID-19 are still experiencing what might be lifelong side effects and ramifications for having had COVID-19. And so healing, I want to argue, must be construed in a broad enough way to be focused on what it means to be whole and what it means to be connected to community, and not necessarily what it means to be cured, right? So this is one way that I think that theologies of healing must be interrogated. What do we believe about the body? What do we believe about purity as it relates to health? These are theologies that are proven fragile in the midst of a global pandemic, right? I thought that if I just pray, if I just have faith, that I will be not only healed, but cured, free from any kind of ailment, anything that's considered non-normative in our contemporary society. But what we know is that you don't need to be fully free from disease to be whole, and to be connected to community, to be cared for, to have joy and experience thriving. So I lift this up as an example to demonstrate that this period of time has been an eye-opener, right, for many in faith communities who didn't realize, took for granted, perhaps, the theologies of healing that they were loyal to. One of the questions that is implicitly present in many conversations that I've been having with people of faith over the last year of pandemic is, in whom can I place my trust? So this follows theologically from a framework about healing, about cure, about illness, about bodies. Who can I trust to keep me healthy? I love to scour social media for what I call theology on the go. And so these are some memes and status updates and whatnot that I have pulled from social media over the past year that speak to the meaning making, theological meaning making that many people are doing during COVID-19. That first meme there, making COVID-19 an acronym that stands for Christ over viruses and infectious diseases, right? So this says something about the extent to which we have sort of hierarchies of priority, right? That my faith is above everything, even COVID-19, despite that the fact that COVID-19 has been ravaging communities for more than a year now, right? The second meme, I don't know if y'all done heard about this stuff, but it can get rid of anything, right? Referring to the blood of Jesus. Again, what theology of healing is illustrated in this kind of meme? And let me just say, I don't show these memes to ridicule or shame a particular kind of belief system or theological framework, but I use these memes to demonstrate that people are doing theology even as they're trying to make sense of something that is not theological, like an infectious disease like COVID-19. The third meme, you look big, but my God is bigger, right? So these illustrate theologies of healing, particular interpretations of biblical passages. And so it's more complicated than we might think. Saying to folk, God loves you and wants you to live, might not take seriously the embedded theologies that are already present in communities throughout our city, state, and country. More memes and screenshots from various social media posts, right? Someone posting the scriptural proof, quote unquote, that the pandemic is God ordained, right? So even using faith, using Bible, using theology to explain the origins of a pandemic like COVID-19. I send an epidemic on my people. This is someone quoting 1 Kings. If they pray and repent and return to me, I will forgive them and make their land prosperous again. Again, this is a theology that must be interrogated and investigated in light of the fact that thousands of people have now died from COVID-19. The second from a religious leader at a congregation in Indiana. This person talking about laying hands on the sick and the sick will recover. So defying state and federal guidelines, encouragement around refraining from religious gathering during COVID-19, because religious gatherings have been, as we know, super spreaders, right? And so again, how people respond connects to the embedded theologies that were present, connects to what people think about healing and cure. This one last one, a tweet that comes from before COVID took off in the way that we saw it take off mid-March last year. But I think illustrates again something about theology, right? I really believe God will break you down until you have no choice but to trust in him. So again, theologizing, speculating about the um, kind of silver lining in COVID-19, or the connection to COVID-19 and God's perfect plan, right? These are all questions that need answers as we try to uh, stay healthy, stay whole, and follow the guidance of medical professionals here during COVID-19. So I'm going to stop there and invite Dr. Gary.
Oh, well, thank you so very much again to Villanova University and to the organizers of this talk, and to you, Dr. Washington, Reverend Washington, for allowing me to participate in this discussion. And boy, I got to tell you, if I had known you were going to pull some ripped from the headline slides that look at the various memes of faith communities about what this pandemic has represented, I could show you equally the memes from the medical community about what the challenges that we have faced helping everyday citizens understand the science behind what is happening in a time when we barely understand the science ourselves and the challenges there. Because I can tell you there's a litany and there's no end to the cartoons, to the graphics, to the believing in science and the need for people to understand and not answer without question or buy into without question what science is dictating, because I think that's folly, but to rely upon basic principles upon which we've all learned about how the universe works, how viruses work, how medicine works, how things like hand washing and masks and all these things. And so I thought it would be interesting to juxtapose the theology, if you will, of what physicians and student doctors, what are we learning in medical education about faith and about the relationship of faith to the practice of medicine that might enable us to perhaps be better providers and begin to marry some of these concepts to produce better community health. And so, this article, the first one, Religion and Spirituality in Medicine, Friend or Foe, is the 2020. We are still having the debate about whether or not religion has a role in healing and in our practices and in our discussions with patients. And it's frustrating for someone like me who considers myself a believer. I have a background in Christianity. I am a person of faith, and working in oncology, where faith is challenged, I think, to its penultimate, because patients are faced with something that is completely beyond their control and for which their mortality is very much in question. How can I negate the faith of my patients, whatever that faith might be, and instead ask them to rely upon something that they completely and wholly do not understand, and that has not regarded their cultural and their spiritual considerations. And so, what we continue to find in medical education is that there is still the debate, and you can see the article on the bottom right, where this psychiatrist is saying, among the many reasons for the continued separation of religion and science is that it might simply be irrelevant to health, or worse, it might have a number of negative health effects. And this particular review article expounds for about 20 or 25 pages on the opinion and the research supporting the claim that religion has no place in healthcare and in medicine, unfortunately. And so I think that it is important for our community to understand the paucity of solid education that doctors are receiving about how faith-based practices can enhance care and enhance healing. And it just is not the case. If you go to the next slide, this is a great review article that talks about the actual and real benefits of spirituality and our health. When we look at things like our longevity, we can see that mortality is decreased, particularly in African Americans. The benefit of religion to longevity was particularly large, and the average lifespan of religious Blacks 14 years longer than that of their non-religious peers. And that age 18 to 54, those who attended church had lower mortality risk than those who attended just once a week or not at all. We can see that upon disease states, cardiovascular disease, arteriosclerosis, liver disease, emphysema, that there is a role for our faith communities in the promotion of wellness, in the adoption of best practices, whether it's things like abstaining from drugs and alcohol, to looking at exercise, to encouraging things like deep breathing and meditation, and focusing on our spiritual and physical beings as connected. That there is a very real benefit to faith-based curriculum and faith-based practices in our health maintenance. And so this is something that I tried to emphasize to trainees, and we have seen the evolution of this, and there are some curriculums, faith-based medicine classes, clubs, there's a Christian Medical and Dental Association, but by and large, coronavirus and this global pandemic has shown a spotlight on pretty much every issue in healthcare that might have seemed of concern, that might have seemed minor, that might have seemed in the background, and it's brought it all to the forefront. And part of that bringing to the forefront certainly does underscore the fragmented relationship between our faith-based communities and our medical communities, and that can really have some deleterious results. And so looking at even the next slide, this is some, this slide I thought to include because it shows the types of data that can be collected. So some of the challenges that we face in healthcare regarding how to best mobilize and galvanize our faith-based communities has to do with the lack of data that's available. Our EMRs are not set up to collect and to utilize data regarding religion and faith practices. And in fact, there's no real distinction between someone's spirituality, their ethnicity, and their faith. And so how we look at this data and who collects this data is of particular concern, because when we find that certain organizations collect the data, they can use that data to advance whatever initiatives that they so choose. And so, looking at this data, for example, children with a learning disability by family structure and religious practice, you can see that children with a learning disorder, who come from single parent families are much more likely to be diagnosed with that disorder. And what types of religious practices do they incur, and what do their family structures look like? And that is juxtaposed with the percentage of children who have these learning disabilities. And it sounds fairly perhaps innocuous until you consider things like, well, 65 to 77% of Black women are single parents. And they are the breadwinners, the sole breadwinners of their households. And so what does this say then about their children and about the propensity of their children to be potentially diagnosed with something like, or to be lumped into a category for something like an attention deficit disorder? And so, the person who does the research then, and if you advance the slide for me, gets to use the data however they so choose. And so if the goal is to advance the cause of marriage and religion, if the goal is to advance the cause of anti-vaccination, if the goal is to advance the cause of disregarding faith altogether in light of a purely scientific approach, whoever's doing the research can manipulate this data. And so I think that this reminds us to be very careful and empiric in how we look at the relationship between faith-based communities and medical practice, and what we're telling our communities from our medical providers, because there's a significant trust factor that has been breached. And I know, Naomi, we're going to talk about this probably in the next slide. But one last slide before we get into the conversation about that is this one. And this looks at traumatic brain injury. And it looks at the benefit of a faith system, the benefit of spirituality upon things like traumatic brain injury. And so you can see that when there's a religious practice and there's perceived social support, there's positive health behavior, there's improved psychosocial status and activity. And this is recapitulated in patients who are recovering from the coronavirus, where there is isolation, where there is a lack of social support, where there are fewer positive health behaviors, we can see poor outcomes. But when those factors are in place through faith communities, through the marriage of solid medicine and faith, these patients can do well. And Naomi, you're absolutely right in that it looks like healing. It looks like optimization of wellness at whatever state and wherever you are, because we have seen the devastation of the coronavirus in terms of amputees, loss of function through strokes. We've seen vision changes. We've seen organ failure. We have seen so much devastation from this that, you know, it has been an important reminder to us as well that the goal of healthcare, the goal of medicine is to improve wellness. It is not always going to be a cure and a restoration of complete and total function to what normalcy looks like. And so that accepting that part of our practice has been exceptionally difficult. But it's something that we need to do a better job of conveying to patients and building and bridging the trust between the practices of science and medicine as it relates to the coronavirus, as it relates to vaccines. Because what we know is that in these communities, in Black and Brown communities, while 60% of Americans say they're going to definitely get a COVID vaccine, only about 42% of Blacks said that they would do so, compared to 83% of Asians and 63% of the Latinx population. We know that 1 in 390 Indigenous Americans has died of the coronavirus. 1 in 555 Black Americans has died of the coronavirus, and more than half of all hospitalizations and all deaths are in Black and Brown people. And so there are some real opportunities for faith-based interventions. And I hope that we can leave today with some similarly forged pathways and inroads forward. And I think we got permission to agitate people a little bit on this webinar today. So I think it's important to challenge some of what we believe and look to do some new things. You know, if our God is a God of newness and new mercies every day, then there's some newness that can come from us and some innovation that can come forward from us regarding how we plan to promote wellness and heal our communities through medicine and through faith. This last slide looks at the vaccination rate in Philadelphia by race and by ethnicity. And this is taken just as of last week. So in Philadelphia, 42% of females and 39% of males are Black. But you can see the woefully low numbers at 17.5% of Black women and 16.9% of Black men have been vaccinated. And this is not just a matter of socioeconomics. It is not just a matter of personal choice. This speaks to structural racism. This speaks to lack of access and poor delivery of care. And these are areas that are discrete and measurable in places where we can improve in the quality of care for our communities so that we can see these numbers improve a bit.
Before we go to the next slide, I want to underscore something you said, Mo, about the importance of faith and spirituality to health and well-being, particularly in a society that is still grounded and rooted in white supremacy, right? One of the things that has troubled me over the past year is sensing the sort of the condescending tone with which people refer to Black and Brown folks, Black folk in particular, as it relates to vaccine hesitancy, as it relates to quote unquote conspiracy theories, circulating myths, circulating around COVID-19. You know, Black faith is not unsophisticated. Black faith is not anti-intellectual. And I think if we see theological limitations, which are validly there, I think, and possible, we must first interrogate the context out of which these theological perspectives emerge, right? And so I want to just underline what you've said about the emphasis on personal responsibility, the emphasis on sort of, as I said, unsophistication, that obscures what should be the emphasis, which is lack of access and historic mistreatment, right? We've heard the narrative that folk are suspicious, rightfully so, in part due to historical mistreatment, abuse, neglect, and exploitation by the medical establishment, which again grows out of the same white supremacist context that all of our institutions have grown out of. This is, of course, a picture from the Tuskegee syphilis study, right? People are saying, generationally, I have not been able to trust that the medicine given to me, that the treatments administered are done for my benefit and my benefit alone, right? And these stories from history have been uncovered and continue to be uncovered. But this is not simply a historical matter. This is what we must highlight and agitate around today. Just today or yesterday, the Philadelphia Maternal Mortality Review Committee, of which I'm a member as a kind of person of faith representing communities of faith in Philadelphia, published a report that found that Black women represent 73% of pregnancy-related deaths in Philadelphia. That's not 1962. That's not 1862. That is 2021. So we're talking about the historic and contemporary experiences of Black folk, of brown folk, of Native folk inside the medical establishment, right? So this suspicion, again, is not unfounded or unsophisticated. It is grounded in the everyday experiences of people when they go to the doctor, when they take their kids to the doctor, right? It feels like every day on Facebook. I don't know about you, Mo, but I scroll my timeline and somebody has had some kind of experience that gave them pause when they went to the doctor, right? And again, I'm not here to vilify the medical community, but what I'm here to say is that people remember how you made them feel.
Mm-hmm. It deserves
mhm.
a reckoning. I got to jump in here because you're
Mhm.
not wrong. And rather than say the mistrust, I say the medical community has not earned the trust of Black and brown folks in this country because of the long legacy of slavery in this country and even what preceded slavery through the Middle Passage. Physicians were aboard those ships just to keep slaves alive long enough to sell them. Right? We can look at things like forced sterilization through Jim Crow, but that's continued until the 1970s with Hispanic women in California and in prisons. You can look at the maternal fetal death rates, right? And you can see that this is a result, not just, and here's the linchpin is that it's not just a result of individual accountability and individual racism, rather structural racism and structural violence that it permeates through the entire healthcare system and healthcare delivery. And that's what we wrestle against, so to speak. You know, it's not the flesh and blood, it's the principality here. If I can, wax a little bit.
Quote it. Go ahead and quote the book. Quote the book.
And what that principality looks like is it looks like a system that was not designed for the health and welfare of these very vulnerable individuals. And so, my question though in return looks like what does redemptive and restorative healthcare justice look like for our communities? Where is the litmus test? Because I see every day in cancer, Black women are 40% more likely to die of their cancer. We are 42% more likely to be diagnosed with advanced disease. We are twice as likely to be diagnosed under the age of 45. We are more mortality. We are only represented in about 3% of clinical trials, right? So what does restoration and what does healing look like to our community, and where is the benchmark for where that healing begins? And that is the struggle, I think, of Black clinicians, few as we are, less than 6% of us in medicine and less than 2% are women. And so we have our work cut out for us as we try to be trusted advisors for our community. But I think as a community, we need to decide how and what healing looks like. What does trust look like? And how does that feel to us so that we can then begin to move forward in really constructive ways? Because while none of these things can be negated or denied, in any way, shape, or form, moving forward, we have to forge a path that looks like it marries our cultural beliefs, our beliefs about food as medicine, about the intrinsic ability of the body to heal itself, about our faith, and about our medicine. right? And about preventive care and access and all these things. So, I think the challenge in our faith-based communities looks like having conversations around what are the benchmarks? What are the metrics? What do we need to see in order to better believe the care that we're getting and that it's trustworthy? Because you can see, even for coronavirus, there were some questions around informed consent for things like hydroxychloroquine being administered within prisons and within nursing homes, because we thought it was the next hot thing and somebody said it looked like a good idea to them. And next thing you know, we're giving this to people who cannot sign informed consent in the name of a global pandemic. And so there's some real challenges in paternalism in healthcare that we need to continue to hold ourselves accountable for to our vulnerable communities.
I so appreciate this last point you just made, in particular around how this period of vulnerability leaves us susceptible to hasty solutions that are at the expense of our most vulnerable, right? When we don't take our time, when we're trying to save face, when we're trying to be the first in the world to develop this or that, we are likely to take that ambition out on our most vulnerable communities. And so I really appreciate that. I also appreciate how you're talking about the reckoning that's necessary. It connects to this next slide. I think there is a theological reckoning that we got to do. Even as I'm saying, we need to take the faith of Black folk, of brown folk, of historically marginalized folks seriously, and not ridicule it, not shame people because of it. We need to understand the origins of those, the socio-political origins of those theological positions. And at the same time, we do need a theological reckoning, I think, in the Christian church. Faith, in my view, is not an escape from life, an escape from perhaps the pain that we experience because we are flesh and blood and bone, but a tether to life. I don't want my faith to help me run from my life. I want my faith to draw me closer to my life, to make me more intimate with my own self, my own body, my own needs, my own desires, my own imagination, right? My own fears. So faith as not a cancellation of all of the things that make me human, but faith as a mirror to my own humanity, which is blessed by God, right? My humanity isn't the problem. My flesh, my body isn't a problem. Don't get me started on our body theologies. But that my faith, it makes sacred my body. And so this is the kind of theological reckoning that I want to help bring about, that I want to pass on to my communities. Also, faith not as an outcome in itself. Remember, we talked about it earlier, faith as healing, faith as wellness itself, faith not as an outcome, but a process, right? So many folks are using faith to make sense of and cope with the devastating realities of their lives, right? And COVID-19, as has been said by many folks, is but one pandemic that people are living through, but not the only, right? We're talking about Black and brown folks, about Indigenous folks, about LGBTQ plus folks. Folks have already been living through life-threatening realities, right? And faith is kind of a process through which we learn how to live and thrive and care for each other in the midst of a world that often is death dealing for many in our communities. So this is the reframe of faith that I think is necessary in order to live and thrive and come out on the other side better as we face this global pandemic. Now, I mentioned earlier how Isaiah is often a text that is invoked when we think about notions of healing. Well, my good friend and comrade in ministry, Candace Simpson, often talks about fish sandwich heaven. What she's referring to is that beloved story of Jesus's miracle working in the midst of a crowd that was hungry, right? What we see illustrated in that text is an example of the kind of care and mutual aid that we need right now during COVID-19. There was one person in the crowd who had a little lunch, right? And that person, I'm drawing back to my Black church roots here, thought it not robbery to avail his lunch to Jesus and put in Jesus's hands. That little lunch became the feast that nourished the whole community, right? What we see in that story is what my friend Candace Simpson calls fish sandwich heaven. Everybody had a little piece of fish, everybody had a couple of pieces of bread, and everybody left that encounter with Jesus full, right? What happens when the faith community and the medical community, both resources of nourishment, right, for us, work together to multiply what looks like not enough and in service to the whole community? What does mutual aid look like when faith organizations, when faith leaders work together with medical professionals like Dr. Mo and others? This is an example that Dr. Mo brought to my attention. The Christian Connections for International Health organization is just talking head on, asking all of the hard questions. That's what I love about this video series on this website. They're tackling the question of who should take the vaccine? Should Christians take the vaccine? What's the moral justification for wearing your mask? How does wearing our mask represent a kind of mutual aid and mutual support that I don't get to live if you don't live, and you can't live if I don't live, right? So I think that faith communities need not be shying away from getting into the science, from being in dialogue with religious leaders. This is another example, I think, of, like Dr. Mo, a medical professional, physician, who is also a person of faith. This is Dr. Gina Smith, who is there at the University of Pennsylvania. She's a local doctor. She's also a Black woman, and she's honest about the fact that because she's a Black woman, she understands the suspicion, and she too had some questions around the COVID-19 vaccine. And she's been transparent enough to tell her story publicly. How did I move from point A to point B as it relates to the COVID-19 vaccine? And how did my faith help me get there? She's also a person of deep faith. Go ahead, Dr. Mo.
May I present for your consideration and or agitation that this analogy of the fish sandwich, while I love it, because it teaches lessons about sharing. It teaches lessons about the amplifying power of God to take something small, a faith the size of a grain of mustard seed, and amplify it. When you relate it to healthcare, and when we take it to the very real place of what we're doing, let's say in the city of Philadelphia, it looks like Dr. Ayla Stanford taking her fish sandwich and spreading it out across the city to try to make a difference in terms of the vaccination rates, where that same effort is not necessary in other communities. And it looks like elders standing in really long lines for vaccines out in the cold. It looks like there's some things that are some inequities, again, are really brought to the surface, because we need to be in tune with the fishers, with the fishermen. We need to be at the wharf. We need to be getting the fish off the boat and not giving up that single sandwich, because in healthcare, I think that when I apply that analogy that way, it makes me angry, quite frankly, because it looks like that we are not doing enough from a policy standpoint, from an organizational standpoint, from a governmental standpoint, not just the city, but the state, not just the state, but the country, to address how we are delivering care to these communities. And so, I got to agitate and say that, these are some tremendous works that the Black Doctors Consortium has done, but look what they've had to work with.
Absolutely. I mean, I agree. I think that, yet again, the folks who have been most impacted by somebody else's misguided, and perhaps not even misguided, but intentional attempt to freeze them out of a system are taxed with the enormous challenge without resources. Dr. Stanford had a van a year ago, and she got some COVID tests and put the SOS out. If you need a COVID test and you have found it impossible to get one, like it was this time last year, come on, we're going to be on the corner of so and so and so and so in North Philadelphia. That's how the Black Doctors COVID Consortium got started, as you know. And so it is enraging. And I think I'm of a couple of minds about it. I think that the work of rectifying the systemic barriers to health and wholeness, the onus of that is on the folks who created the problem. And so I think that we're agitating here. I can't see all of the 88 people who are listening. But I challenge the people who find themselves distanced from the lack of access, the lack of respect, the lack of compassion and concern, should be the ones raising hell, if I can say it that way, to make these systems move. And in the meantime, people who are on the margins do what people on the margins have always done. They have created pathways to their own health and wholeness. And that's something I want to celebrate. I'm mad about it and I celebrate it. And so here's the slide to lift up the Black Doctors COVID-19 Consortium that has led the way, that has, and I say this as a person who works for the city, has in some ways outpaced, not in some ways, has completely outpaced the city in responding to the need, the gap in care during the COVID-19 pandemic for Black and Brown neighborhoods in Philadelphia specifically. They didn't ask a lot of questions about how and who and when and how much. They just bought a van, got the van, and got the COVID tests and showed up, and then got some vaccine and just started telling people, come on, come on, come on. And so that's why I say this is not unsophisticated. This is a gospel kind of response to meet the need of folks who are hurting and dying in our communities. Same thing is true with faith leaders in Philadelphia who have said, look, we're going to open the doors of our church. Okay, we can't come in here to worship, but we can make sure the place is ready to go so that medical professionals can come in and administer COVID tests and administer the COVID vaccine. Go ahead.
And Naomi, I think that we had a webinar early on in this pandemic, and we talked about what faith leaders and faith communities can do to address some of the gaps in our community as it relates particularly to things like access for young people for Wi-Fi services and for safe places to do their homework and to go to virtual school and to get a hot meal. And we did see faith communities step up. Our churches in Philadelphia and surrounding counties really did answer the call. One, to be availed to the community for purposes other than worship, in safe ways, providing chaperoning and social distancing and all these things that, formerly community centers used to do. But, we've seen a lot of the funding of those community centers fall to the wayside, but the churches have filled in the gap. And I think that the communities have in turn responded with their tithes, with their offerings and financial support to keep these places of worship afloat. And moreover, in partnering with our medical centers, looking at that particular article, Mainline Health is partnered with churches along the main line and in West Philadelphia.
Right.
I think we should similarly see hospitals in North Philadelphia and hospitals out in the Northeast and hospitals, in Germantown and Chestnut Hill begin to do the same things and partner with these faith communities to provide services to the community. And that to me is truly the promise of what the pandemic has brought upon all of us, is that we can recognize our humanity and our empathy and our ability to unite together to promote better health, for our communities.
That's right. I mean, what I'm trying to do at the city as the director for Faith-Based and Interfaith Affairs is do exactly that. Facilitate, make it easy and smooth, eliminate the red tape so that we can partner in ways that are effective and impactful for our communities. Early in the pandemic, we heard the call from faith leaders who said, come use my building. We're not in there for worship, but we know people need food. People need, as you say, places for their children to go, perhaps when folks have to go to work, essential workers have to leave the house, right? And so we set up some programs through which faith organizations, houses of worship could help with food distribution, could help with volunteering. We needed a lot of volunteers early in the pandemic, and we set up the structures on the back end to make sure that people could sign up to volunteer in their communities during a critical time like the beginning of the pandemic. I've been fortunate enough to be able to be a messenger, right, to help to craft the guidance that the city is designing for religious communities, and to do so with compassion. At the bottom here, you see that we actually had prayer led by many different faith leaders from different faith traditions early in the pandemic. This is back when we were still going into City Hall, no masks. Eek. I look at these pictures, I'm like, when was this? But what we wanted to do is say, yes, we need our health commissioner to get up and give us the raw data, give us the facts and figures, tell us what COVID-19 is and how it works. We also need a word of encouragement. We need somebody to get up and say to us, it's okay if you're afraid. It's okay to be anxious. It's okay if you're up to your eyeballs in stress because you've got, 3 children under the age of 8 at home, right? We needed someone to help us, again, make sense of and draw closer to the realities of our lives. And that's what we tried to do in those early press conferences. We published resource guides for faith leaders. How can we support people who might need mental health care services in our congregations? How can we observe religious holidays? And we're right back where we started, right in the middle of Lent in the Christian tradition, getting ready to go into Passover next week, getting ready to go into Ramadan later on in April. People needed guidance on how can we celebrate, how can we observe and do so safely. And so we tried to publish that guidance. Worked with the Department of Public Health to design some graphics. I said, we need some graphics, something that people can pull up on their phones, something people can print out and post. How is it that we should worship safely? We're not asking people to worship less. We're asking people to worship safely during COVID-19. And so we published these graphics in 6 different languages, hoping that people would use them to get the quick and dirty about how to worship safely during COVID-19. Dr. Mo referred to this, the very first webinar that I hosted for faith leaders about the COVID-19 pandemic was on Saturday, March 28th, 2020. And Dr. Mo was one of the Black doctors that we engaged to specifically talk to Black folk about how to navigate COVID-19. And here are some other webinars that we've done over the course of a year. You'll note that we're trying to get at all of the concerns of people of faith, not just what is God doing or will God heal me, but also how can we move our services to virtual environments? How do we care for a multi-generational congregation if we can't see them and touch them, right? How do we, again, celebrate holidays? What are the legal concerns I need to have if I'm going to have folk in my building, right? And so the other thing we recognize is that life didn't stop during COVID-19. I think I read yesterday, we've had 7 mass shootings in the last 7 days in the United States, right? We still have the same problems we had before COVID-19. And so we wanted faith communities to feel empowered to still address those same problems, even though we're socially distancing. So we talked about domestic violence and how we might protect people who are not actually safe at home. We talked about how we might support public school students who are navigating the grief of losing their connection to their friends, to teachers who cared for them during COVID-19. And we talked about stopping violence and healing trauma in Philadelphia during COVID-19. We've continued to pray. You know, we say we are people of faith. We are people of moral courage. We want to pray. We want to meditate. We want to contemplate what's happening. And so since March, I believe it was 19th last year, we have every week, now every 2 weeks, been praying online, just a little digital space, 15 minutes or so. I invite a faith leader from Philadelphia area to come and lead us in a word of encouragement and nourishment. This too is faith. This too is necessary for healing and wholeness, to the points that we were making earlier, right? Get your vaccine and get centered. Pray. Do whatever you need to do to access the transcendent in your life. Go ahead, Dr. Mo.
I was just going to say, and also do not be afraid to voice that faith to your providers and to raise the questions. You know, it is okay, it is acceptable, it is necessary and essential to ask your medical providers about what you're receiving, about what you are seeing, about what you are experiencing and what to expect. And I think that when the medical community tries to distance itself from things like faith, from things like topics surrounding healing and wholeness and wellness, things surrounding things like nutrition. I think that there are some opportunities to really dig in and lean into your faith and bring it back to the forefront. Because if you look at the data, you know, 78% of physicians or more say that they're people of faith. They believe in something. They believe in someone. They believe in a higher power. They believe in God. And so connecting with that and reminding them of that and what that faith then dictates for them in their practice is something that is very powerful to tap into. And so I think the mandate then becomes, you know, as you exercise your wellness, as you move forward with your vaccine, with your screenings, once again, because screenings are down for colon cancer, breast cancer, cervical cancer. We have to get back to the business of looking out for our healthcare and challenging our providers as well to incorporate and ask about our faith. You know, I can't tell you the number of patients who have, I've had to stand in the gap, because during the coronavirus, they've not been allowed to have their family members. You're facing a cancer diagnosis, the biggest surgery of your life, and your family can't be there. Your pastor can't be there. Your spouse or your partner can't be there. And the number of patients who have just said, you know, would you hold hands and pray with me? And the ability of our team to do that, or to play worship music for them during their surgery, you know, or to sit with them in meditation and solidarity while they believe and practice whatever it is that they believe, is something that's powerful and redemptive and connecting and unifying. And like, that's an opportunity, you know. And so the clarion call for physicians and for, you know, medical students and for those who are in healthcare, nurses and, you know, nurse practitioners, whoever's watching, is to tap into that. And to unite with patients around what they believe and not be afraid to bring those things up and bring them to the forefront and be an agitator in your space, in your clinic, in your practice, because that's the source, you know, from which all things come.
I love that. Just the paying attention, being attuned to each other, right? We are, again, living in a context that seeks to, I think, disintegrate us. To dismember us, to say, well, I'm a religious person when I'm in my religious community. And while I'm at work, I do whatever kind of work I do, and I'm that kind of professional when I'm at home. But I think that what spirituality does for me is it brings me back together. It puts me together again, right? In the midst of a society that seeks to rip me apart. Here's another example of exactly what Dr. Mo is talking about. What we wanted to do is say, look, people are grieving all kinds of losses, not just the loss of life, but loss of routine, loss of predictability about the future, loss of the ability to do what you do to get away from your house when you need to get away from your house, right? And so we wanted to just set a space where people could talk with trained professionals, right? We had psychologists, psychiatrists there, counselors, about what it means to be grieving right now. I was fortunate enough to have somebody from a church in Newtown, Connecticut, who could talk to us about what does it mean to be a community reeling from loss, right? Like Newtown was those several years ago when the mass shooting happened at Sandy Hook, right? And it was so good. It got so good. People said, do a part two. I got somebody I want to invite to come who wasn't on here this time. And so we did a part two. How do we stay connected and nourished in the midst of so much grief and loss? And then we said, listen, we got a lot of caregivers right now who don't feel like they have anybody to care for them, right? And so what does healing look like for the healers in our community? We had a session for caregivers. And then, as I said, life didn't stop. We needed to also grieve as a community about the death of a Black trans woman here in Philadelphia. And so I helped to organize a community grief session in the wake of that. Winter solstice, we had a virtual experience for people who felt like, man, this year took everything I had, and I'm going into 2021 with nothing. I need a place to go to say that. I'm not feeling the joy of the Christmas season. I'm feeling despair. I'm feeling frustration, right? And so we had a service on the longest night of the year where people could virtually come together and say, I just need to lay my burdens down, right? We had a vigil in the wake of the uprisings that happened in Philadelphia after George Floyd was killed, right? And we had faith leaders from all over the city to be present and to offer words. What do you say to a community that is struggling to breathe in all of the ways, right? We got COVID that's robbing people of breath, and then we've got racialized violence that's robbing people of breath. What do we do? And so again, to Dr. Mo's point, we need to create more spaces where people feel like they can be transparent about their need to be connected to something greater, something more, something deeper. And then we also celebrate, right? We say, listen, it's been a hard roll. It's been a hard year. This is a hard week in the midst of a year of hard weeks, right? That's what can we celebrate? What can we have joy about? Well, these were annual events where we would gather on Boathouse Row in Philly. We couldn't do that this year or in 2020. And so we did it virtually. Let's come together and celebrate anyway. Last slide. So we also wanted to mark the time, right? We've been a year in this thing. And we wanted to name that, hear from our mayor, hear from faith leaders who helped us reflect on, we've lost a lot, and maybe we've learned a lot too. So let's reflect on the losses and on the lessons of 2020, of the past year. And so looking forward, one of the things that we were able to do is get clergy promoted to the 1B phase of vaccine eligibility in Philadelphia, because we understood that as faith leaders themselves get connected to what is wholesome and healthy, they will pass on that message to the communities that trust them. And so clergy were moved up to phase 1B in Philadelphia. And we're going to have a conversation after Easter about the moral reasons, the moral justifications for getting a COVID-19 vaccine. So we'll stop there. I see a couple of questions have come through the Q&A. So Mo, what do you want to do? You want us to just take the questions, or you want to bring Catherine in? Or
we can take these questions. And I think what I'll do is I'll read them out and we can go from there. So the first question is, well, does the graph with the vaccination numbers that came from the Philadelphia Inquirer just last week, does that include in prison populations? Individuals in prisons and jails have received such low quality of care during COVID-19 and have been placed at an extremely high risk of contracting it and not receiving care for it. So I'm wondering if they're even included in the demographic information that we see about vaccinations. And the answer for that first question is no. That information was taken from the U.S. Census for Philadelphia residents. And so in prison individuals were not included in those numbers. And I dare say that if we were included, the numbers would be even lower. And so I think that we have a significant amount of work to do. My nephew is a correctional officer, and I tried to give him masks at the very beginning of this. And he said, no, he says, we have to wear the sheets that the prisoners cut up, and we're not allowed to bring anything in. And we have to, and the conditions were so suboptimal. And we saw that there was a real crisis of morality around how we were treating incarcerated individuals. And we know who's disproportionately incarcerated in and around this city.
Right. There was an effort made in an open letter written by faith leaders. I was one of the signatories to the district attorney in Philadelphia to, early in the pandemic, release folk who were being held in jail pre-trial. And so there has been some organizing and some agitation among some faith leaders locally to make sure that folks who are incarcerated either get released because they don't need to be there. It's impossible to socially distance in incarceration. Or let's expedite this process. I know the courts are closed, so what does that mean? That people just languish? And so there has been some advocacy around that. But Dr. Mo is right. We're not anywhere near where we need to be in terms of taking care of those who are incarcerated.
Mm-hmm.
Yeah.
The next question is, how house segregation and redlining influence the health or medical help provided to people of color? And the answer is in myriad ways. There are statistically significant associations between redlining and pre-existing conditions like things that portend higher morbidity and mortality for COVID-19, like asthma, COPD, diabetes, hypertension, high cholesterol, kidney disease, obesity, and just access to fresh food, fresh fruits and vegetables, right? We have seen the churches really step up to provide fresh food for these communities in food deserts. And so the answer is that redlining is a huge part of the structural racism that creates the structural violence and vulnerability that we see in these communities that contributes very directly to the increased morbidity and mortality as a result of the coronavirus, but even above and beyond the coronavirus to everyday just health, health and wellness.
There was another question in the chat about whether or not this conversation will be made available to folks. And the answer is yes. This is being recorded and this will be posted, I believe, on the Center for Peace and Justice Education website after this talk is over. And so please feel free to share this. Are there any other questions? You can go ahead and put them in the Q&A.
For you, Naomi.
Oh, okay.
In the spirit of Oscar Romero, what do you want folks to be agitated enough about to take some action about after this lecture and moving forward? What are the ways that people can take some of this agitation and convert that potential energy into kinetic energy?
Yeah, I think that every church that I've ever been a part of has had a health ministry, right? Somebody who is a retired nurse or current nurse who's taking it upon themselves to keep health top of mind in congregations. Well, I think we need to roll out some robust health ministry in each of our congregations, and not just that once a year let's run around the block 5 times and be healthy. I'm not knocking that. That's a good thing. But how are we partnering formally with the health care providers in our community? Do you know the clinics in your zip code? Do you have relationships with physicians such that you can have a webinar in your congregation and invite trusted medical professionals to answer the questions of your congregation? We have seen through this pandemic how much there is a gap in kind of medical knowledge. And we know this is intentional, right? We're talking about vulnerable communities. And so this access has been forbidden for so long. So what we need to do is make sure that we have solid partnerships with the local healthcare providers in our community, right? The other thing I was talking to my spouse about this, to what extent do we reinforce some of the problematic thinking related to healthcare because we have not been in relationship with doctors like Dr. Mo, right? We don't know anything about the Black Doctors COVID Consortium, right? We're not in relationship with people who come from vulnerable communities and who can talk with lived experience about these subjects. We reinforce that our experts are people who don't look like me and Dr. Mo. And so what would it mean for faith leaders, for white faith leaders, for white congregations to take it upon themselves to be in solidarity with healthcare providers of color and organizations like Black Doctors COVID Consortium, right? It's the riskiness of transgressing the boundaries that have been erected by a white supremacist system, right? So those are a couple things that come to my mind, how we can be agitative. Yeah.
I think you're absolutely right. And I think moreover, using the resources to partner with faith communities that have less resources. This is a wonderful opportunity for churches to unite in some of those health ministries and partner with some of the smaller or some of the more local churches that just don't have the same amount of resources. It's a good time to extend that olive branch and to get involved so that the community health can look a bit different. Because as we look at the questions, someone says Trevor Hoppen, Punishing Disease, talks about the problem with individual responsibility frame with respect to HIV/AIDS. And there was some framing with COVID about protecting others. But is there still not enough communication that the community is caring for folks? The answer is no. There is still not enough communication that the community is caring for folks because, what we see in Black and Brown communities is a direct correlation and a result of that historic lack of care from those communities and a lack of organization and a lack of resources within those communities. And so it can look a lot different. This could all be different.
It could have been so different. It could have been so different.
It can be if communities will reach across their geographic boundaries, reach across their disciplines, reach across their different sects of religion, and begin to show what community and what caring can look like.
That's right. Brian asks the question, are there any learned lessons or new measures that we believe will continue in underserved communities after we come through the current crisis? Brian, I'm going to be honest with you. When I first read the question, I said, no, I think people will take their bags and go, right? This is what we've seen over time. We've seen renewed scrutiny and perhaps investment in vulnerable communities during the acute period of disease. And then let's go back to status quo. And that's what we're encouraging not to happen, right? People keep saying we want to get back to normal. Well, I don't want to go back to the silos that we were in before, the disparities that we've experienced all this time, right? So I hope that this investment will be multiplied and sustained from now on. It'll just be, this is what we do. I hope so. Historically, that has not been the case.
I'm an optimist. I'm a cancer doctor, and so I have to be. And so my answer to that is, in terms of learned lessons and new measures, I would say amongst community members, I have seen renewed interest in learning how food can be medicine. I have seen folks with little patios, no patios, a windowsill, planting their own gardens and trying to learn how to grow their own food. I have seen renewed interest in things like mental health and mental health services and the expansion of mental health services as a result of the virtual world that we're now living in. So resources can reach people who may have had transportation barriers. I have seen additional resources with respect to things like virtual doctor's appointments, and people who haven't seen a doctor in, I can't tell you how long, Zooming and FaceTiming with their physicians for the first time in a long time. And while it's not a surrogate for an in-person examination, I mean, you can't listen to a heart over Zoom, you know, seeing and talking to that doctor while they're not typing away is restoring some of that relationship. You know, I've seen Black doctors and nurses and physician assistants and students, right? The student doctors, everybody is trying to do their part. And so I'm hopeful. And I'm really hopeful that, you know, in the Black and Brown communities, especially in Philadelphia, that we are recognizing that we cannot continue to lay such hold to some of the attitudes that we've had about our preventive health, because we continue to get the worst of everything. And that it looks like contact tracing and clinical trial participation, and it looks like considering things like vaccines, or even just asking the questions, even if you're not going to get it. Ask the questions, do the research, read the articles, and challenging what we have been historically taught and what we have believed and what's been handed down to us as a result of trauma. And so I'm real hopeful about it. I truly am.
I agree with you that I think that communities that are vulnerable are going to innovate and be creative and make a way out of no way. I think that is our ancestral heritage. I think that we come from a long line of folks who made a way out of no way. I think I am hoping that I too can be hopeful as it relates to the dominant systems that have for centuries shut people out, and might have a bit of courage to invest and to make reparations, essentially, for historical and contemporary wrongdoings. I'm hoping that that is what is sustained, that we see at the policy level, as you said earlier, changes that prevent us from sliding back into that status quo. I hope so.
Tied to the ramifications, tied to reimbursements, tied to, you know, funding, tied to this horrible looking data. Like, you know, why do we continue to call ourselves the greatest nation in the world when we have these abysmal rates of, you know, of Black maternal mortality and you know, the healthcare disparities? So I think that, you know, we can't sweep it under the rug anymore. The rug has been removed, and all that remains is the dust, and it's time to start sweeping it up. So I hope that it remains exposed, and I hope it does so until we replace and fix the structures and, like you said, the policies that govern how and who gets the health care and who gets the best of the health care, and fix some of these inequities toward parity.
That's right. That's right. I love this as a close to a sermon, right? A wound has to be exposed before it can be treated. I love it. Love it. Love it. And so I hope that what we've shared today is of help and a resource. Certainly, we want to say thank you again to the Center for Peace and Justice Education and Dr. Catherine Geddick-Soltis, who extended this invitation to us. And here she is.
I just want to thank you both so much. This was so rich. There was, I mean, so much knowledge here, so much integration. And there's my head is spinning from so many things that you shared that I just want to think more about and unpack. So the creativity and the profound, the love and humanity that you have given to us today, I just am so appreciative. And I especially want to highlight, you know, what you both have spoken about in terms of wellness and flourishing, right? And wholeness. And, you know, and that speaks right to what we're about today in terms of the Solidarity Lecture, right? Because if we are truly deeply concerned about flourishing, right, of everyone, then we cannot help but be sensitive and outraged by the injustices and the disparities and the lack of trust that has been earned, right? And so I am just so grateful that you bring us to this, that the invitation to flourishing, the invitation to wholeness is an invitation to justice. It's an invitation to solidarity. So Thank you both so much. And I, as you were talking about ending a sermon, I just want to say to everything that you both shared with us today, amen. So thank you. And thank you all for being with us today. We'll be posting this video as soon as we can get it up, and I hope you can share it with many others.
Amen. Thank you again.
May it be so. Thank you.